Greetings. I will be doing part 3 of diabetes now. This will be the final section of this, but there is other sections on the other endocrine disorders. This seems like a lot of content. Focus on what I've been emphasizing and making sure you understand the content, and when you don't, you contact me and I'll be glad to go over anything that I can. I have posted PowerPoint part 3 with and without notes, so if you will pull those up now and have your book ready. Mainly in your book, we're going to be focusing on pages 1317 through 1340. 1317 through 1340 in your Med-Surg book. All right, we're going to be talking about mainly, like I said in part 3, the complications and things they need to watch for. So when we're talking about a type 1 diabetic, type 1s are at risk for what we call DKA. Diabetic ketoacidosis. You rarely ever see this in type 2. Only almost always in type 1. So this is the big complication you have to watch for. There are two etiologies. Either number 1, the patient has poor compliance with insulin. In other words, they're not taking their insulin. Or number 2, increased endogenous glucose. They're taking in too much glucose, as in being on extra steroids that could boost it way up. That's why when you have a patient who comes in who's a diabetic and they're on the steroids, you want to make sure you're checking those AccuChecks very closely. Looking at the patho of DKA, hyperglycemia, which is what starts this cascade of unfortunate events. When you have hyperglycemia, you've got more blood sugar particles in the bloodstream at that time than you do fluid. Okay, so it's concentrated. So hyperglycemia increases your plasma osmolality. Okay, you got more particles. And the blood becomes hyperosmolar. The extracellular fluid then is going to draw from the intracellular fluid because things go from a lesser concentration to a greater. And now in the extracellular fluid compartment, we've got more particles because of all this extra glucose floating around. And it actually leads then to cellular dehydration and osmotic diuresis. As DKA progresses, glucose in the blood is in the blood and not in the cells. Okay, so there's no insulin on board to take it into the cells, so it just keeps building and keeps building and building. Well, unfortunately, the G's, remember our glycogenolysis and our gluconeogenesis. See, the cells are starving to death. They don't have glucose, so what do you think they do? They try to help. So this results in a further increase in glucose levels. Fatty acids then are converted to ketones because remember the long-term versus short-term. If we don't have glucose in the cells for energy, then it's going to use whatever it has at that time and convert it. So we'll start breaking down fats. We'll start breaking down proteins in the muscles and the cells to use them for energies. Ketones then accumulate, so we become ketoacidosis. So that is diabetic ketoacidosis. The ketoacidosis is from the ketones accumulating. Now your bicarb and your sodium become lost because the buffers is gone to the diuresing. Your respiratory rate becomes altered because remember you're in acidosis. So what are you going to do with your respirations? You're going to speed those up, trying to blow off that CO2 and decrease that pH. This is called Kussmaul's respirations. And it is normal for a diabetic who's in DKA to have Kussmaul's respirations. It is normal. Acetone and fruity breath is very common with people who's in DKA because of all the extra glucose and ketones. Serum potassium is your big thing. In fact, potassium is what kills a lot of people who are in DKA because it's going to appear normal or elevated. But remember what's happened to the cell? Remember you pulled everything out of the cell, you dehydrated and shrunk that cell, so the cell itself is actually depleted, even though it appears that it's elevated in the extracellular fluid compartment. Insulin, remember way back at the very beginning on part 1, I said has many functions. Remember this one. And one of the functions insulin had was the transport of potassium into cells. Well, with this in DKA, you don't have the insulin. So it's not transporting the potassium into the cells. So that also leads to hyperkalemia. So clinical manifestations is going to be mental status changes, which we know that from acidosis, nausea, vomiting, abdominal pain, hyperglycemia, Kushmal's respirations, fruity odor to your breath, hypothermia, hypovolemic shock, polyuria and glycoluria. We have glucose in the urine. And what happens in the kidneys, if you remember back to A&P, in the filtration system of the kidneys, the glomerular filtration rate. When you get down to the kidneys, they can only absorb or reabsorb so much glucose. And the threshold is 180. So when your sugar starts getting above 180, instead of reabsorbing it, it's going to start spitting that out in the urine. So you will get the glycoluria. Water loss can be astronomical, anywhere between 4 and 12 liters with DKA. So let's think about osmolality with DKA. Your serum versus your urine, okay? Well, we said it's hyperosmolar, didn't we? Because we said there's a lot more glucose particles floating around. So doesn't it make sense the serum is hypertonic? The serum is hypertonic. But look what's going on with water loss and the diuresing because of all the extra glucose. If you're losing 4 to 12 liters, you're pretty much losing at the end almost pure water. So your urine becomes hypotonic. So you got your serum being hypertonic and your urine being hypotonic. Lab findings in DKA, hyperglycemia, of course. Hyperkalemia, but remember, that is not actual. It's got what we call transient hyperkalemia because the cells themselves, remember, have been shrunk and are actually depleted of potassium. For the first 4 hours, they will be in hyperkalemia. So when they come in, it's going to look like they've got a high potassium level. And then between hours of 4 and 24, as you are starting insulin, because what's insulin do? Insulin takes potassium back into the cell, and it does that pretty rapidly. So where you originally started out with hyperkalemia, once you start that insulin drip, you're going to go to hypokalemia pretty quick, usually within 4 to 24 hours. That's why don't freak out if the doctor comes in and orders a low dose of potassium in the IV fluids to start, even if it looks like their lab's a little high, because they know once they start that insulin drip that potassium level is going to go down, because that insulin's going to carry that potassium back into that dehydrated cell. You're going to get metabolic acidosis because you're throwing off too many ketones. Leukocytosis if they have an infection. White counts can be greater than 10,000. Dehydration, expect increased serum osmolality in this case because you've got increased glucose, increased hematocrit, and increased bun. Because you've got more particles than you do solution. Just remember what you're measuring. Okay. Management of DKA. Well, insulin. Okay. Because what started this whole cascade of events? Lack of insulin or too much glucose, as in steroids. And for the most part, usually it's lack of insulin. So they're going to start a drip of 5 units per hour, up to 10 units per hour with hourly blood sugars to make sure they don't drop that too quickly. Remember, hyperkalemia is quickly going to be reduced with your fluid and insulin replacement because you're going to dilute it down with the fluids that you're given, and the insulin's going to take that potassium back into that dehydrated cell, because then the extracellular fluid compartment, the potassium level is going to go down as it's rehydrating the cells. The initial fluid is normal saline, and usually they'll give a liter over an hour or less, pretty quick, okay, because you want to get those fluids back in there. Followed by 1/2 normal saline, about a liter every 2 hours with 20 to 40 milligrams of potassium, depending upon the potassium level. So they're going to be monitoring that potassium level very closely. When blood sugar gets to back down to 250 or less, a lot of times they will go ahead and change that over and give D5W, D5NS, D5.5, something with some dextrose in it. And this is necessary because we got to restore all those muscle and liver stored forms of glucose in the form of glycogen, because remember, we've depleted all that when our G words kicked in, trying to help because they knew the cells were starving. Acidosis is reversed with insulin because it inhibits fat breakdown. So once we get the insulin on board, we don't need to break down our fats and our proteins anymore, because insulin carries that glucose back into the cells to use for energy. INOs, vital signs, they may actually have to be on a central venous pressure monitoring depending upon how bad they are. Note, hypokalemia is a major cause of death in DKA. Hypo, not hyper, because the deficient is intracellular, so don't be fooled. That's why we administer potassium early. Remember that. So just the mnemonic, a little mnemonic and a little pictorial for those of you who like these sorts of things to help you remember DKA. The onset can be over 4 to 10 hours. Mainly, if you look at their history, they could have been sick, or lack of insulin being the huge one, or increase in glucose. What are you going to expect to see? Well, they're going to have the fruity gums, so tutti frutti, Kushmal's respirations, thirsty with dehydrated, tachycardia, hypotension, acidotic, high blood sugar, hyperkalemia, and polyuria will be present. So what are you going to do for these people that's in DKA? You're going to high E. They need a high E. They need hydration, insulin, and electrolyte replacement, right? Particularly potassium. So you're going to high E people who's in diabetic ketoacidosis. All right, complications for type 2. Remember I said you do not see DKA hardly ever in type 2. In fact, instead of that, you're going to see what is called HHNS or HHS. HHNS stands for hyperglycemic, hyperosmolar, non-ketoic. So they don't get the ketosis, but they still have the hyperglycemia and hyperosmolar. The client produces enough insulin to prevent DKA with type 2, because remember, they do have some insulin on board, but not enough to prevent HHNS or HHS from occurring. So they still have hyperglycemia, they still have osmotic diuresis and dehydration, but they don't break down fats and proteins because they have some insulin on board. So insulin is still taking some glucose to the cells to be stored. So no ketones, no amino acids are being broken down, therefore no acidosis. And that is the main difference between HHNS and DKA. With both of these, you have hyperglycemia, you have hyperosmolar, you have osmotic diuresis, you have dehydration with both. But the main difference is with DKA you have metabolic acidosis because you have no insulin. With type 2, HHNS, you do not have acidosis because you have some insulin. If that don't make sense, holler at me. Now, with HHNS, it's going to be extremely high glucose levels, usually 600 plus. Hyperosmolarity because of the increased glucose levels in your intracellular fluid compartment, which causes osmotic diuresing. So how do we manage HHNS versus DKA? Well, again, we're going to give normal saline for the first 2 liters here during the first hour of treatment. Then they may switch to half normal. When the blood sugar falls to 250, they're going to give D5W, D5NS, or D5.5NS. IV insulin for hyperglycemia is for the hyperglycemia in this case, not the acidosis. If you'll remember, in DKA, it helped with both of those. Once they started the insulin drift, it helped with the hyperglycemia and it helped with the acidosis. With HHNK, the main focus is to get the blood sugar level down because you do not have acidosis. So you will start it at a much lower rate, 2 to 5 units per hour, as compared to DKA, 5 to 10. Now, potassium is not as much a concern because, again, we've got some insulin, so it's been taking it into the cell. With DKA, potassium is an issue. Complications of type 1 and type 2, hypoglycemia we worry about, remember, and that is any blood sugar less than 60. Now, some people tolerate a 60 fine. Some people at 60, you can't arouse them. Some people tolerate a 500 well. Other people are in a coma at 500. Everyone reacts individually to different blood sugar levels, and it's what their body's getting accustomed to. So you want to treat the signs and symptoms that you see in a patient. Etiology for this is too much insulin in this case, too little food once you've eaten, or excessive exercise. Just some personal accounts I have. I did have a sister after pregnancy with her first child. She had diabetes. She almost didn't make it because we know that your sugar drops anyways after pregnancy. I had a grandmother who went into a retirement home to see about living there and ended up having some issues. I ended up with pneumonia and did not make it. And then I had a nephew who because of the excessive exercise and not taking a snack, didn't make it. So, diabetes is dear to me, and this is part of the reason because of my personal accounts. Clinical manifestations: decreased glucose stimulates the central nervous system, the sympathetic nervous system, to release epi. Now, one of the things we know about epi is it is a counter-regulatory hormone. Remember, epinephrine, norepinephrine. But once you release that epi to help with the decreased glucose, it also stimulates the signs and symptoms, which is trembling, the shakes, nervousness, irritability, pallor, tachycardia, confusion, cold sweats, fatigue. So this is why you see a lot of these signs and symptoms in someone who's hypoglycemic because of the release of extra epi. Treatment: we're going to ingest a simple fasting acting carb as an orange juice, a soft drink, hard candy. Once they improve, you always follow that with a longer acting carb, such as milk or bread, graham crackers, and that, because that just brings it down real quickly and it can rebound with those G's in your body and come back with a vengeance. So you always want to follow it with a longer lasting carb once they improve. If the patient is not NOT, not alert, then you don't put anything in their mouth. Administer glucagon 1 milligram sub-Q or IM, and it's just giving straight into the thigh. And what that does is stimulates, if you'll remember what glucagon does, stimulates the liver and other muscle cells to convert glycogen, the storm form of glucose, back into glucose. In the hospital, of course, if you're in the hospital, then they're going to give an amp of what's called D50. And an amp of D50 comes in the larger syringes. It's almost like pure sugar, thick water, and it is very, very hard to push. So you're going to push with all your might and push it just as fast as you can, and it's still going to go slower because you have to really push to get that in. One of the things I want to remind you of is glucagon injection. If you ever give that to someone who's got glucagon at home, can induce vomiting right after they get it. So once you give someone an injection of glucagon, you always position them on their side. After you give glucagon, you always position them on their side. So just a little acronym for hypoglycemia is tired, tachycardia, irritability, restlessness, excessive hunger, diaphoresis, or depression. So let's look at some of the chronic complications that affects both type 1 and type 2. Because some people get type 2 and are under the misfortunate thinking that nothing's going to happen to them because they can't see any of the effects of what's going on inside the body. But they are just as risk for chronic complications as type 1. You've got macrovascular versus macrovascular changes. Of course, micro meaning small. So we're talking about thickening of things like the capillary basement, membranes, and if you do that, of course, you decrease tissue perfusion to those areas. So things would be like retinopathy, neuropathy, and nephropathy. So you're affecting the kidneys, the brain, the eyes constantly when you keep blood sugars high. Macrovascular changes can be alterable, again, with controlled blood sugars. So what this is saying is if you can get someone to keep their blood sugars under control, then you're going to keep them from getting macro and microvascular complications in the future. Examples of macrovascular would be like coronary artery disease, peripheral vascular disease, and CVAs. Unfortunately, they can affect a lot of people. So one of the things you need to keep in mind, there's some things that can occur, and we're going to talk about two conditions of fasting hyperglycemia and the dangers of those. Two conditions of fasting hyperglycemia. In other words, when you go to check their sugar, they check their sugar in the morning extremely high. And what's the dangers of reacting to that? There is a visual in your book. Let me see if I can find it. I'm sorry, I should have had the page number written down, but I didn't. On page 1315. 1315 goes over the Samogi effect, the Dawn phenomenon, and lack of available insulin. And it shows you the three blood glucose phenomenon in patients with diabetes and how that occurs. So let me explain first what they are, and then we'll look at this chart. Hypoglycemia during the night, the Samogi effect. What you're going to have is hypoglycemia, during the night with rebound hyperglycemia in the morning. It is more common in type 1. Because too much insulin is circulating at night. Hypoglycemic episodes occur at night, and they're going to cause the release of what? Dun, 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 counter-regulatory hormones. And the counter-regulatory hormones are epi, norepinephrine, glucagon, growth hormone, cortisol. Now, what do we know about these levels, too, as far as their circadian cycle? That's when they normally increase, particularly growth hormone and cortisol. About 4 or 5 o'clock in the morning is when you're really seeing them peak in their levels as far as when the body's producing them. So that can further cause some issues closer to the morning when you're actually ready to draw those levels, because these are counter-regulatory hormones that's going to spit out glucose closer to the morning time when you're checking that AccuCheck. Clinical manifestations, these people complain of nightmares, early morning headaches. That's the two big things you'll say. Man, we had some vivid dreams. They seem like I could just reach out and touch that person. Management, well, the way we find out if someone's having this Samogi effect, which we call rebound hyperglycemia, is we go in and check a blood sugar at 2 a.m., 4 a.m., and 7 a.m. What we would expect to see if they have too much insulin circulating at night would be a decreased sugar at 2, a starting to increase at 4, but a very high one by 7, again, mostly because these counter-regulatory hormones have kicked back in by then. Plus, the level had gotten so low, some of your G words had kicked in, right? So, what could be the danger of this? Well, the danger could be the healthcare provider may assess the situation as hyperglycemia when they check that early morning dose. So, what are they going to do? Increase the insulin dose. If they increase the insulin dose, what do you think might happen again at the next night? It may go down even further. So you really have to make sure that you are watching for this Samogi effect. The dawn phenomenon, on the other hand, is early morning rise in blood sugar. Whoops, let me go back to previous. And I better make sure that didn't mess up. Hold on just a second, because it went off my radar. No, it didn't. Okay, sorry about that. I didn't want to have to do this for nothing. Okay, the dawn phenomenon is early morning rise in blood sugar with no hypoglycemia during the night. So this is more common again in type 1, so you're going to see these in type 1. It's related to nocturnal elevations of growth hormone and cortisol, especially prevalent during adolescence, pregnancy, and young adulthood. So we call this the dawn phenomenon, but mainly you're going to see this with your adolescents. And part of that is because of the growth spurt. So they are going to be pushing out even more growth hormone, so that it looks like early morning they have a very high blood sugar level when it's actually related more to these nocturnal elevations, and that will decrease throughout the day. Again, the danger is that you may see that as very high blood sugars and try to give them more insulin. Management is change the time and dose of insulin, and that's pretty much the management of Samogi effect. So that's what they are not getting the insulin at that time. So you want, with either one of these phenomena, you want to decrease the insulin dose or change the time of the injection. For example, if they're on an intermediate, they may take it at 10 p.m. so that it peaks about the time growth hormone and cortisol levels are released. Okay, hope that makes sense. So before we do our checkpoint, let's go back to our book here and look on page 1315. And you can see here that the three phenomenons in the counter-regulatory activation, you can see just from lack of insulin that your sugar would go completely up during the night, right? If you're talking about the dawn phenomenon, then it's going to start out pretty level, but when you get to about 2 or 3 a.m., it's going to be a little bit lower, but not much. It's just leveling out. But by early morning, it's very high again, and that's because your counter-regulatory hormones have kicked in. Now, if you look at the bottom one, this emoji effect, you can see when at 9 p.m. it was pretty normal. But what happens at 2 to 3 a.m.? See, it took a big dive downwards in the 60s. Then by the morning, it's way up again because of those counter-regulatory hormones. So make sure you know the difference in the dawn phenomenon versus the emoji effect and how we treat it. So let's do a little checkpoint at this point and see where we are, okay? Joe Green is 18, has type 1 diabetes. Yesterday, he was admitted to your unit with flu-like symptoms. He tells you that he hasn't taken his insulin for the last 3 days. Uh-oh. And he can't eat solid foods. I don't know about you, but I'm already thinking DKA, not taking insulin. Mr. Green is at risk for developing diabetic ketoacidosis as a result of what? A, polyuria, B, dehydration, C, lack of insulin, D, decreased appetite. And you should have picked C. When a patient has type 1 diabetes, we know that they have absolute lack of endogenous insulin, right? They have to take exogenous replacement or, Humulin. He's at risk for developing hyperglycemia and DKA. Polyuria is simply just a symptom of hyperglycemia, and if left untreated, it can cause dehydration. Decreased appetite alone, of course, doesn't increase the risk of DKA. So when assessing Mr. Green, you notice that his respirations are deep and rapid. Kushmal's, a sign that his lungs are attempting to do what? Increase the CO2, decrease the CO2, increase the bicarb, decrease the bicarb. Well, hint, hint, if you'll remember back in ABGs, I told you the lungs can only mess with CO2. That's the only thing. So you could have marked C and D off immediately. Bicarb has to do with the kidneys. CO2 has to do with the lungs. So am I trying to increase the level or decrease the level? So you should have picked B. When a patient experiences DKA, ketones and acids are spilling over in their bloodstream. So we know the respiratory system compensates by trying to eliminate that excessive acid. So during this process, respirations we know become deep and rapid, Kushmal's respirations, to decrease carbon dioxide levels. We're trying to compensate for the patient being in metabolic acidosis. Your assessment of Mr. Green's neurological system will probably reveal alert mental status, lethargy and disorientation, tremors, and seizures. Now, even if you did not know this answer, let's look here. If you couldn't remember that acidosis depresses the central nervous system and that alkalosis stimulates it, alert mental status, tremors, seizures, all those three have something in common. Stimulation of the central nervous system. There's only one oddball one that's depressing it. That's lethargy and disorientation. And the answer is B, lethargy and disorientation. Again, that is secondary to your acidosis. You'd expect Mr. Green's arterial blood gases to show what? Decreased pH and increased bicarb, increased pH and decreased bicarb, increased pH and increased bicarb, decreased pH and decreased bicarb. If you'll remember, pH and bicarb go the same direction. pH and CO2 go opposite directions. So you should have picked D. In a patient with diabetic ketoacidosis, fat metabolism decreases, we know, fatty acids and ketones, decreasing your blood's pH. And we also know that that is the base part. So if you've got less of it, then you're more likely to have acidosis. Martha Evans is admitted to your unit with type 2 diabetes. During your assessment, she tells you that she drinks a lot of fluids and urinates frequently. Polyuria in patients with diabetes is primarily caused by A. Hypertension, B. Increased osmolarity of the blood, C. Hyperkalemia, or D. Altered fat metabolism. And you should have picked B. Polyuria commonly occurs in patients with diabetes because of increased osmolarity of the blood, and that's associated with the hyperglycemia. And we know that directly leads to osmotic diuresis. Which of the following statements is correct about type 2 diabetes? Less than 50% of diabetic patients have type 2. We know it's the most common and more than 90%. Its onset is abrupt and clients often present with DKA. We know that type 2 do not have DKA. They have HHNK or HHNS or HHS, whichever one you want to call it. The signs and symptoms are also not abrupt. Remember, they're insidious and they sneak up on you. So that marked out the first two answers. C is the predominant type of diabetes in young adults. And we'll remember type 1 mainly occurred in young adults peaking in 10 to 15 years of age, where type 2 is more prominent in those older adults, particularly 50 and older. So before we even know the answer, we know it's D because we done eliminated A, B, and C. It develops most commonly in midlife and later. The last one, glycoside or glucotrol, is a second-generation sulfonylurea. It's commonly used to treat type 2 diabetes because it does what? Stimulates the secretion of cortisol. Well, if it stimulated the secretion of cortisol, what would that do? Increase your sugar level. And what do oral hypoglycemics do? Decrease your sugar level. So we know that one's not correct. Increases serum glucagon levels. No, because that would increase your glucose level again. So that marks off A and B. Increases insulin production and the number of receptors on cells. Delays absorption of glucose. And the answer is C. It's an oral hypoglycemic agent that stimulates the beta cells to produce more insulin and increase the number of receptors on cells. It also decreases hepatic glucose production. So that is where we are. So hopefully you are on track. If you're not, then you probably need to give me a holler. Okay? Other topics related to diabetes. Foot care. Foot care is an important thing. Foot injury is the most important complication. We know that it leads to amputations in diabetics particularly. Half of your diabetics get hammer toes and claw toe deformities, cricoid's foot, and there's a good picture of that in your book on page 1325. Now you can see if that was your foot, how hard it would be to wear shoes. Okay. Decreased blood flow with flowing healing. And if you don't know what hammer toe and claw toe looks like, then Google those because you need to know. Neuropathy, we know, causes tingling, burning, and itching, and can end up with complete or partial loss of sensitivity to touch and temperature. They can walk around for hours with rocks in their shoes and other things and never feel it. So that's why they get a lot of wounds on the bottom of their foot. They are also can be at risk for foot ulcers. A lot of times they will go in and do what's called a monofilament test to see what kind of pressure they can feel on the bottom of your foot. This also detects neuropathy. So if you look on your book on page 13, 26, and 27, it talks about the diabetic foot. You want to assess the patient who's got a risk for the diabetic foot ulcers, and it also goes into foot risk categories. Category 0, 1, 2, and 3. So you can look over those on table 64-10. So it goes over some things about diabetic foot care in chart 64-5, so you can look at those. And then it talks about doing the monofilament test. And it says that you really have to do a good exam to make sure to see if they are having any issues. So on the top of page 1326, it says a person who cannot feel the 10-gram pressure on any point of foot is at risk for ulcers. To perform this exam, what do? You provide a quiet, relaxed setting. You ask the patient to close their eyes during the test. You get what we call a monofilament, and y'all will be doing this. And you test it on their cheek so they know what to expect. And then you test the sites that are noted in figure 64-7. So I'm going to take this monofilament that has 10 grams of force, and I'm going to place it on the big toe and those 3 major areas under the toes. And then I'm going to apply the monofilament at a right angle to the skin surface. And I'm going to apply enough force to bend the filament using a smooth, not jabbing motion. So you don't jab it. You just use a very smooth motion. And it shows you the correct technique on page 1327 in figure 64-8. The correct technique for sensation testing with a 10 milligram filament. You want to apply the monofilament to the designated area on the foot sole. Intact skin only. Don't be doing it over ulcers or known calluses because they're probably not going to feel it. Apply pressure either until the patient states they can feel it or until the monofilament bends. Once it bends, if it's bending a lot, they can't feel it. Quickly remove it without sliding it or touching other areas of the foot. The approach and removal of the filament at each site should only be 1 to 2 seconds. You want to apply it again, not over any calluses, scars, or necrotic tissues, and you don't want to slide it. You just simply say, close your eyes and tell me when you feel this. If they can't feel it and it's bending quite a bit, then they probably have neuropathy. All right, so now you know how to do a monofilament test. So things to remember before teaching. The scope of low literacy, health literacy in the United States is very important to keep in mind. About 40 million Americans can't read or write, so don't assume every time you walk into a room they can. And of those, about half live in poverty these days. The U.S. reading level is about the 8th grade level. Most pamphlets are written at about the 10th grade level, so a lot cannot understand the pamphlets you are giving them. Watch labeling clients as non-compliant. Sometimes they do not have the resources at home, so make sure you're assessing that before you send them home. Assess the level of knowledge very carefully. Patient teaching related to foot care, they need to check their feet daily. They need to wash their feet with mild soap and lukewarm water. No lotion between toes. Take care of toenails, especially after bathing when they're softer. You want to tell them if they're going to trim their nails, they want to do that straight across and don't cut close to cuticles. Taking care of corns and calluses, they need to see physicians. They do not need to cut them off themselves. They also need to be very careful of over-the-counter meds because a lot of those products contain acid, and that can cause skin ulcerations and infections. If you're putting a lot of acid and you can't feel it, you may be putting on more and more and actually burn the bottom of your foot. Protect the feet. Make sure they're getting shoes that fit well. There are diabetic shoes. They're not the prettiest, but they are made for diabetics. Keep blood flowing well. Work with the other healthcare teams. And make sure no nylon socks. They need to use cotton. Patient teaching related to diet and exercise. Well, with type 1, it may be we actually want them to increase their calories. Diet and insulin are both necessary for control, and it may actually let them decrease their insulin dose a bit. Additional carbs are required for physical activity when type 1 are doing activities. With type 2, it's just the opposite. Usually we are doing dietary modifications to decrease caloric intake because most of these people are obese. Low-fat diet, no snacks are recommended unless they're on insulin. And you do need to remember these. Protein count should be between 10 and 20%. Remaining 89 to 90% should be between your fats and carbs. 50 to 60% carbs, 30% fats. Of the fat, saturated fats should be less than 10%, and your cholesterol should be no more than 300 milligrams per day. Now, some of your newer research also supports that fiber helps in the dietary management, and that diabetics should have at least 25 grams per day. Should have at least 25 grams per day. And of course, things high in fiber are like your beans, your cereals, your fruits and vegetables, your whole grains, and things like that. Of course, while less fats, and that's because of the known risk of MIs and strokes and blood vessel diseases. Research is also supporting that maybe giving diabetics up to 5% of their diet with some simple sugars may help them be more compliant, other than saying you cannot have any simple sugars at all. Some helpful hints: use non-stick cooking spray instead of your butters and oils. Limit your butter, salad dressings, and gravies. It's not sounding pretty, is it? Eat less fried, more baked, broiled, and grilled, steamed. Choose 1% skim dairy products. Eat red meat no more than 3 times a week. Season your food with low-fat flavoring, spices, Mrs. Dash. Use sugar and salt in moderation. It's mainly complex, not simple sugars. Alcohol, to indulge or not to indulge. Of course, adults, if they are going to anyways, then the suggestion is 1 to 2 drinks per day. 1 for women, 2 for men. Drink is considered a 5-ounce glass of wine, 1.5 ounce of hard liquor, or a 12-ounce beer. And really, the key is not to indulge. And the reason they say not to indulge is because it can induce actual hyperglycemia. And even though most people think it's hypoglycemia, when you're taking in too much alcohol, the liver has to choose what it wants to do. And a lot of times, it's going to choose to get rid of that alcohol versus messing with converting glycogen back over to glucose. So you have to watch for hypoglycemic reactions, and your book talks about that, and you can read up on that, especially if they're on oral hypoglycemic agents. Now, we all know that diabetic foods can be expensive, so and that the labels can be very deceiving. If something says low fat, then it's probably high in sugar. If something says low carbs, it's probably high in fat. There's always a trade-off. The use of sweeteners are acceptable, even though lots of research out there points to potential issues of long-term use of sweeteners. Sugarless, sugar-free, be careful of the packages. Again, sometimes when it says that, it's high fat content. So always make sure they're checking their caloric content as well. If they're going to be exercising for type 1 and type 2, for type 1, it's usually to increase your sensitivity, and it may actually let you lower your insulin dose, where with type 2, it's usually weight reduction. So the goal is to exercise 60 to 80% of your maximum heart rate for the client. So how do you figure that? And you need to know this. Subtract the age from 220 and multiply by 60 and 80%. Thus, if you had a 20-year-old, you would subtract 20 from 220, get 200, multiply that by 60%, and you get 120, multiply by 80%, and you get 160. So their heart rate when they're exercising should be 120 to 160. Exercise, remember the acronym FIT: frequency, 3 times a week; I, intensity, 60 to 80% of your maximum heart rate; and T, aerobic, you want to do 20 to 30 minutes with a 5 to 10 minute workout. Pediatric considerations are on 992 through 1006 in your PEDS book. We do know the incidence, unfortunately, in type 1 and type 2 are increasing in children. 1 out of 3 will actually develop diabetes. The most common endocrine disorder in children now, and we think it's because of the rampant increase in adults, because remember, type 2 is hereditary. There's also a MODY type, which is a mature onset diabetes that doesn't occur until they're actually adolescents. And there's a cystic fibrosis related type because of the problems with the pancreas. But this one is hereditary based. Some general principles: you always want to ask about weight loss, and polyuria can be mistaken for enuresis at night. No caloric restricted diet. Sweets and juices can be worked in. If they're under 7, then they get 3 meals and 3 snacks. If they're over 7, then they can omit the mid-morning snack. This is particularly important for school, when they're in school, that the school nurse, the teachers, and the coach are all on board, particularly if they play sports, because they are going to need snacks and carbs prior to exercising. The hemoglobin A1C goals for this age group is a little bit different. For 0 to 6 years, you want to keep their goal at 7.5 to 8.5. That's stable. 6 to 12, they want to keep it less than 8. 12 to 19, less than 7.5, and then over 19, less than 7. So they keep theirs a little bit higher. Diabetes in children, what is their role? Well, as they get older, they should be doing more and more. You can start out as young as toddlers. They can wash their hands. Preschoolers, they can pick which finger you want them to stick. Preschoolers can actually start, depending upon the age, and closer to school age, can start collecting the blood. And children, remember, only can handle teaching in small spurts. About 15 minutes is about all they can handle, where an adult can handle about 45. School-age children can give an injection with supervision. And which age group has the most difficulty adjusting, do you think, to diabetes? And the answer is adolescence. And if you think about it, that's a time of stress. They're trying to be perfect. They're trying to fit in with their peers. And diabetes is making them different. Some of them will be more upset about not getting a candy bar. Will be more upset about a candy bar than they will about an injection. They would rather take an injection any day rather than not get that candy bar. Now, adolescent girls with diabetes tend to have frequent fluctuations of their blood sugars as well, especially immediately before, during, and after their menses. Well, that about covers the whole month, doesn't it? But things like stress, divorce, stressful learning, a home environment, all of those can increase blood sugar levels as well. One of the newer things that's out there is called acanthosis nigricans, and what this is a condition marked by thickening or hyperpigmentation of the skin. And it's a common sign of insulin resistance long before it progresses to diabetes. So it's almost a warning sign. And you really need to start making this a part of your routine assessment with all obese children. All you simply have to do is look at the nape of the neck, their armpits. It can also be elbow, growing, and abdomen areas, but these three are the most common areas. Or the two is the most common, the nape of the neck and the armpits. I have put some YouTube videos on here for you to watch. Be sure that you go back and you watch those. As far as grading, there is a grading system, grade 1 through 4. You can see grade 1 is just a simple line on the back. Grade 2 is 1 to 2 centimeters. Once it gets to 2 centimeters, then it would be considered a grade 3, 2 to 3 centimeters. Then once it gets to 3 centimeters, it is considered a grade 4, greater than 3 centimeters. Some other things to keep in mind, DKA in children is considered a medical emergency. Recurrent urinary tract and vaginal infections, particularly candidus, are often warning signs of type 1 in adolescents. So you've got an adolescent who just keeps having infection after infection after infection, UTIs, vaginal infections. Then you really want to monitor them and make sure they're not developing diabetes. In children, 8-hour fasting will be greater than 126. Their random will be greater than 200. And their oral glucose tolerance greater than 200 on 2 occasions. So pretty much the same criterion as the adult. Does insulin requirements change as the child grows? Why or why not? And the answer absolutely is yes. And that's because they're going through the growth spurt. And we know the counter-regulatory hormone, particularly growth hormone, increases during that time. Therefore, it would increase the sugar levels. Oops, I think I passed one. Let me go back to the previous. Other things to keep in mind, most children are controlled with BID injections, and most children actually have went to pumps. They prefer them. They're easier to control. They keep their diabetes under control better, and insurance companies have gotten a lot better about paying for them. They want to maintain in children their blood sugar between 80 and 120 is a good ballpark figure. So, considering a child's developmental level and diabetes care being essential, the RN should include which information in teaching the parents of a recently diagnosed toddler with diabetes. Select all that apply. Allow the toddler to assist with injections. No, that was school age. Prepare meat, vegetables, and potatoes with each dinner. No. Test the toddler's blood glucose every time he goes outside to play. No. What if he went outside to play 20 times in that day? Allow the toddler to assist with cleaning off their fingers. Yes. Allow the toddler to choose food selections from options offered. Yes. Remember, toddlers like choices when appropriate. So you should have picked D and E. The sick day rules occur when you have a child who's got diabetes who's sick. You're going to be doing frequent blood sugars every 1 to 4 hours. You're going to be assessing them for ketones in the urine. They need to take their insulin or oral hypoglycemic agents. And a lot of times people think, well, they can't take their insulin because they're sick. Well, if they don't take it, then they're going to get in trouble because the G words are going to pick up. And they're going to kick in, and that level's going to go high. Monitor INO, temperature, mental status. Test for ketones. If vomiting, diarrhea, and fever persists, then you want to make sure you're giving them plenty of liquids to keep them hydrated and providing calories. Some of the latest research that's out there is inhaled insulin, which you would take supplemental at meal times to decrease the postprandial blood sugars. Intranasal, supplementing your meal times. Non-invasive measures of blood glucose monitoring would be the glucose sensor, the watch, measuring it via saliva and tears, measuring it via finger probe, particularly like you do pulse oximetry. So they are looking at non-invasive ways so that diabetics do not have to stick their finger. So far, they have not been 100% successful with any of these methods. Insulin patch, giving it kind of like a transdermal delivery system, is something they're also looking at. End-of-life issues. What's your thoughts about keeping strict diabetic control at the end of life? Should you do that? And the answer is no. My grandmother, when she was she wanted certain things to eat, and we were giving them to her to eat. If we know that they're on in hospice, or we know that they're not going to make it much longer, then really isn't that important. The last thing to remember is wish more for diabetics. You always want to wish more. You want to do weight control, insulin management, sick day rules, hypoglycemia, signs and symptoms and management, know those. The maintenance of foot care, no smoking, revving up the engines to exercise, and making sure they do eye care and evaluation. All right. Don't forget, laughter is the best medicine. All right. If you have any questions or concerns, feel free to call me. I've enjoyed this lecture, and I hope you have too.